Welcome to this educational program. This module provides some basic introductory information about prostate cancer. This module is meant to be viewed by men who may have been diagnosed with this condition or those who are just interested in learning about it. There are other modules available that discuss other aspects of prostate cancer in greater detail, including specific treatments and how to go about making a treatment decision. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. The prostate is a chestnut-sized gland situated in the pelvis at the bottom of the urinary bladder, the place where urine is stored. It sits next to the rectum and surrounds a portion of the urethra, the tube that carries urine from the bladder out through the penis. This is another drawing showing in 3 dimensions how the prostate surrounds the urethra at the base of the bladder. The prostate has 2 important roles. It is a muscular gland, and these muscles can have a gripping or squeezing effect around the urethra. As such, it plays some role in helping to control urine flow and prevent leakage of urine out of the bladder. More importantly, the prostate functions as a male sex gland. It secretes a thin, milky fluid into the semen that nourishes and helps activate sperm cells by liquefying semen after climax, freeing the sperm to travel towards the female egg. As one of a man's sex glands, the prostate is affected by male sex hormones, which stimulate the activity of the prostate and the growth of prostate cells. The chief male hormone is testosterone, produced almost entirely by the testicles. This drawing highlights how the prostate is associated with the reproductive tract. Sperm is made in the testicles and travels through the sperm duct, or vas deferens, and into the ejaculatory ducts. It then mixes with fluid from the seminal vesicles and prostate just before ejaculation, where the semen is released at orgasm or climax. During orgasm and ejaculation, semen passes out of the body through the long tube within the penis called the urethra, which is also the tube that urine passes out through. This drawing shows another view of the male reproductive organs in detail. Prostate cancer occurs when abnormal prostate cells, fueled mainly by testosterone, grow uncontrollably to form tumors. Most of the time, this occurs without any symptoms. Rarely, a prostate tumor can interfere with normal bladder and sexual function, and if malignant or cancerous, can invade nearby tissues and organs and enter the bloodstream or lymphatic system, spreading to form new tumors throughout the body. Prostate cancer does not behave the same in all men. Some prostate tumors can be small, slow-growing, and present limited risk to a patient, while others can advance rapidly and threaten a patient's life. Though all prostate cancer is potentially life-threatening, early-stage disease can be cured. Prostate cancer is one of the most common forms of cancer in men. More than 234,000 Americans and approximately 20,500 Canadians will be diagnosed with the disease this year alone. It is the most frequently diagnosed solid organ cancer in North American men, and it is more common in African American men than in white men. Interestingly, prostate cancer may be deadly in some men, but less important in others. Overall, it is the 3rd leading cause of cancer death in men, and there is a 3% chance of dying from it. This translates to about 30,000 deaths in the U.S. this year and 4,300 deaths in Canada. Fortunately, death rates from prostate cancer have fallen slightly in the past 4 years. As mentioned on the previous slide, about 1 in 3 men will develop prostate cancer, but only 1 in 6 will actually be diagnosed with it in their lifetime. That means that more men die with prostate cancer than from it, indicating that it does not behave aggressively and ultimately threaten life in all men. Although the cause of prostate cancer is not fully understood at this time, research has indicated several risk factors for the disease, including race, age, and family history. As noted, it is more common and also more deadly in African American men. It is even less common amongst Asians and Aboriginals. The chance of it being detected also increases with age. It is rare before age 40 and most commonly discovered in men older than 65. Finally, prostate cancer can run in families. There is a more than 2 times increased risk of developing prostate cancer if you have a father or brother with it. Certain substances in our diets may also impact on the chance of developing prostate cancer, and many things are being researched. Suspected risk factors include high levels of fat, calcium, and red meat. Diets rich in fruits and vegetables and antioxidants may protect against cancer. Prostate cancer begins with changes in just a few gland cells, and often these changes are patchy throughout the prostate. These abnormal cells may grow to form tumors or nodules that can be felt. Tumors may eventually grow large and extend outside of the prostate. Cells may also spread through the lymph or blood vessels or along nerves to reach other areas in the body far away from the prostate. This slide summarizes how prostate cancer can grow and spread. Locally, the cancer can grow through the capsule of the prostate, into the seminal vesicles, beneath the base of the bladder where it can block the ureters, or into the rectum or wall of the pelvis. If cells spread into the lymph channels, which normally carry cells that fight infection and injury, they can spread first to the nodes in the pelvis, and later to more distant nodes in the abdomen, chest, or neck. Finally, if cells get into the bloodstream, they tend to spread first to bone, and sometimes to liver, lung, or other organs. As mentioned, the majority of men with prostate cancer have no signs or symptoms of the disease. However, some men may rarely experience urinary symptoms, such as a weak or interrupted flow of urine, frequent day or nighttime urination, or pain with urination. Blood in the urine or semen may also be described. Persistent pain in the back, hips, pelvis, upper thighs, or other bones are also a symptom. Weight loss, night sweats, and loss of appetite may also be described. Prostate cancer may be diagnosed in 3 ways. These days, it most commonly is picked up during screening for the disease, which will be discussed shortly. Less commonly, it is found by chance when a man undergoes a prostate operation to relieve urinary symptoms, called a transurethral resection of the prostate, also known as a TURP or tupper. Rarely, as noted, a man may present with symptoms of advanced disease. Physicians use screening techniques to detect prostate cancer as early as possible, when treatment is most likely to be effective. Screening means looking for cancer before symptoms ever appear. The 2 prostate cancer screening tests that aid in early detection are the prostate-specific antigen, or PSA test, and the digital rectal exam, or DRE. PSA is a protein made by the prostate and released into seminal fluid and the bloodstream. The test used to detect PSA in the blood is very accurate, and PSA therefore provides an excellent marker to measure the activity of the prostate gland. Along with its use in screening for prostate cancer, it also has an important role in monitoring men with prostate cancer and following the effects of treatment. PSA is discussed in greater detail in its own separate module. A rise in PSA tells us that something is happening in the prostate. Unfortunately, it does not tell us exactly what is happening. There are 3 main prostate conditions that may be associated with an elevated PSA. Benign or non-cancerous enlargement of the prostate, called BPH, inflammation of the prostate, called prostatitis, and prostate cancer. Recent rectal examination or passage of an instrument, such as a tube or catheter down the urethra, can also cause the PSA to rise, but this is usually insignificant and short-lived. Ejaculation may also cause a slight rise in PSA, and it's recommended that one abstain from ejaculation for a couple days prior to the blood test. This slide shows graphically the differences between these most common prostate conditions. So what is a normal PSA value? PSA is measured in lab units called nanograms per milliliter. It used to be that a strict upper limit of 4 nanograms per mil was used for all men having their PSA tested. Studies have shown, however, that because most men's prostates grow larger with age, their expected normal value for PSA increases with age. This table lists the normal ranges for PSA by age and race. These age-adjusted ranges are helpful in narrowing down who might require a biopsy to rule out prostate cancer. Compared to a single cutoff value, they allow doctors to be more accurate at picking up prostate cancer in younger men, while less likely to unnecessarily biopsy an older man. Having said all of this, many doctors now hesitate to use any strict cutoff values for PSA, and are more concerned with relative changes in PSA for a given individual. To improve the accuracy of PSA in diagnosing prostate cancer, several methods have been proposed. Age-adjusted ranges were discussed in the previous slide. So-called PSA velocity, free PSA, and PSA density are other variations of the PSA blood test that may have a role in making it more specific in determining the cause of an elevated value. In the future, other forms of PSA may be measurable and have greater value than our current test. PSA velocity is the rate at which PSA is rising with time. In general, a slow, steady rise is more likely to be due to benign enlargement, or BPH, while a rapid rise is more likely to be due to prostate cancer. The cutoff value that is most widely used is 0.75 nanograms per mil per year. In other words, if your PSA is rising by more than 0.75 points per year with at least 3 measurements taken, then your doctor may be more suspicious of prostate cancer and more likely to suggest a biopsy. It is important to know that PSA levels fluctuate in men with normal, healthy prostates. The PSA velocity is only a guide. In the blood, PSA may become bound to 2 other protein molecules called anti-chymotrypsin, or ACT, and alpha macroglobulin, or alpha-MG. The standard PSA blood test measures the level of both free and bound PSA in the blood. However, labs are now able to differentiate between the 2 forms. PSA from prostate cancer cells tends to be more sticky than PSA from non-cancerous cells, so it is more likely to bind to these other molecules. As a result, in prostate cancer, the percentage amount of free PSA goes down. As mentioned, more detailed information on this subject is available in a separate module. Along with PSA, the digital rectal examination, or DRE, is an invaluable tool to detect prostate cancer. In this special examination, a physician inserts a lubricated, gloved finger into the rectum. Because the prostate gland is just in front of the rectum, the doctor can feel for a change in prostate size, shape, or texture, which could suggest the possibility of cancer. Although a digital rectal exam may feel a bit uncomfortable, it takes less than a minute to complete. If a PSA result is elevated and/or if a digital rectal exam shows an area of hardness or firmness in the prostate, a transrectal ultrasound-guided biopsy is used to confirm or rule out a diagnosis of cancer. In this procedure, after local freezing is given, an ultrasound probe is inserted into the rectum and the prostate is visualized and measured. A biopsy needle is then passed alongside the probe and 6 to 12 prostate tissue samples are taken, depending on the preference of the center. The samples are then sent to a pathologist, a specialized doctor who will examine each one and determine whether or not they contain cancer. The results are then sent to the physician who ordered the test. At this point, many men are curious as to their chances of having a positive biopsy given their PSA level, DRE findings, and other information. A mathematical model or calculator has been developed that can use this data to predict the likelihood of a positive biopsy, and we include the website address here for those who might be interested. When cancer is present in a prostate biopsy specimen, the pathologist will grade the prostate cancer cells according to how much they differ in appearance from normal cells. The grade indicates a tumor's aggressiveness, in other words, how fast it is likely to grow and spread. High-grade tumors are the most aggressive and the most likely to progress beyond the prostate. The most widely used grading system for prostate cancer was developed by a doctor named Gleason, and the grade is therefore called the Gleason grade or Gleason score. The Gleason grading system involves inspection of the arrangement of cells in the prostate glands and comparing this to the arrangement of normal gland cells. Higher grades indicate that the cells are growing more aggressively into more abnormal-looking patterns. Grades 1 and 2 are close to normal and are rarely even reported these days. Grade 3 is clearly abnormal but considered the least aggressive form of prostate cancer. Grade 4 is more aggressive looking, and grade 5 is the most aggressive. When the pathologist inspects the biopsy samples, he or she will not only assign just one grade, but will actually take note of the 2 most common grades seen in the entire specimen. These 2 Gleason grades are added together to give us what is called the Gleason score. Because the possible grades go from 1 to 5, the possible scores go from 2 to 10. As mentioned on the previous slide, however, grades 1 and 2 are no longer reported by most pathologists, so the score now goes from 6 to 10, with 6 being the least aggressive form, 7 being intermediate, and 8 to 10 being the most aggressive form of prostate cancer. Along with PSA and tumor grade, the stage of prostate cancer is another important measure that determines outcome and treatment. Stage refers to the extent of cancer growth as a whole. In other words, it answers the question, is this cancer confined to the prostate or has it spread beyond the prostate? There are 3 components to determining stage, which relate to how the cancer behaves. They are the local extent of the tumor, called the T stage, any spread to lymph nodes, called the N stage, and any spread or metastasis to other body organs, called the M stage. Each component, T, N, and M, is defined to determine the overall stage of cancer. The T stage, or local tumor stage, is determined mostly by digital rectal exam. There are 4 categories as follows. In Category 1, the tumor cannot be felt on DRE and was detected by PSA or by chance during prostate resection or TURP. In Category 2, 1 or more lumps or nodules can be felt on DRE, but these nodules are contained within the prostate. In Category 3, the tumor can be felt to be growing into or beyond the outer limits or capsule of the prostate, and in Category 4, the tumor has grown right through the capsule of the prostate into the wall of the pelvis or the rectum or bladder. This slide shows graphically the details of the staging system that defines the local extent of tumor, or T stage. You may pause here to review this closely if you like. This slide illustrates some examples of these various T stages, with the tumor shown in red. You can appreciate that the extent of tumor increases in the higher stages. Intuitively, the chance of successful cure is highest with the lower stage tumors. The N stage refers to spread of cancer to the lymph nodes. In so-called low-risk situations with a low PSA and low-grade tumor and a low T stage, the risk of spread to lymph nodes may be so low that a physician will not even evaluate specifically for it. In higher-risk settings, however, nodes can be evaluated by imaging tests, especially CT scan, and by surgical removal, called a pelvic lymph node dissection, done usually at the time of prostate removal. This slide shows graphically the details of the staging system that defines local extent of lymph node involvement, or N stage. You may pause here to review this closely if you like. Finally, the M stage refers to metastases, or spread to other body organs. Evaluation for this is only required in higher risk situations. The workup may include lab work to check liver and kidney function, a bone scan, chest X-ray, and a CT scan or other imaging tests. Diagnostic imaging tests, such as a CT scan, may be done if a patient's PSA level is greater than 20 and/or if the patient is to receive radiation therapy. A bone scan is done if a patient's PSA level is greater than 10, the Gleason score is greater than or equal to 7, the cancer is stage T3, and/or if symptoms are present, such as bone pain. Plain X-rays or an MRI scan are done if the bone scan results are suspicious but not conclusive, and a PET scan is sometimes used when an MRI scan is inconclusive. Prostasint is a special type of scan touted to detect microscopic spread of prostate cancer, but is currently not widely used. This slide shows graphically the details of the staging system that defines the extent of distant metastases, or M stage. You may pause here to review this closely if you like. There are usually a number of treatment options available for managing prostate cancer. The treatments recommended by a doctor will depend mainly on the stage and grade of the cancer and the patient's general health and age. This topic is addressed in detail in a separate module. Regardless, for early-stage prostate cancer, the aim of treatment is cure, while for later-stage cancer, the aim of treatment is to extend life and help relieve symptoms. This slide summarizes the many current and emerging therapies for prostate cancer, according to the clinical situation. In some men, it may be best to simply monitor the situation and not intervene with therapy if it is felt that the cancer will not impact on life expectancy. This is called active surveillance with possible delayed treatment. In many men, however, treatment is aimed at curing the disease. Such treatments can be grouped according to whether they have a proven track record and well-defined long-term outcomes or not. These are listed here and are discussed in more detail in separate modules. Finally, some men present with incurable disease or experience a reoccurrence of cancer after other treatments. In these men, along with possible local treatment to the prostate by one of the above methods, so-called systemic therapy with hormone treatment or chemotherapy may be required to control the disease as long as possible. The outcome or prognosis of prostate cancer depends on a patient's PSA level, his Gleason score, the stage of cancer, the number of positive or cancerous biopsy specimens, and his age, general health, and support system. Though the number of men diagnosed with prostate cancer remains high, survival rates are improving. It is estimated that perhaps 89% of men diagnosed with the disease will survive at least 5 years, while 63% will survive 10 years or longer. To summarize, prostate cancer occurs when abnormal prostate cells, fueled mainly by testosterone, grow uncontrollably to form tumors. Risk factors for prostate cancer include age, race, family history, and possibly diet, and the majority of men have no signs or symptoms of the disease. The two prostate cancer screening tests that aid in early detection are the prostate-specific antigen, or PSA test, and the digital rectal exam, or DRE. Diagnosis of prostate cancer is made by biopsy, and diagnostic imaging tests may help to see if the cancer has spread. The important factors which determine a man's prognosis and treatment are the PSA level, the grade of cancer, determined by the Gleason score, and the stage of cancer, along with his age and general health. Standard treatments for prostate cancer include surgery, radiation, and active surveillance with possible delayed treatment. Careful follow-up is an important part of prostate cancer management. These are just a few of many online resources available to educate you on prostate cancer and help you find support. There are also many books written specifically for patients with prostate cancer, and this is just a sample of several. These may be available at your local medical library, bookstore, or prostate center. These medical references were also used to assist in preparing this presentation and may be available for review at your local medical library. We sincerely hope that this module has furthered your understanding of prostate cancer. We wish you the best for the future, and thank you once again for viewing this educational program.